All right. So today we got Gordon, who's a physical therapist based at UK and used to work with, I know you used to work with Dan Path and like Stu McMillan, like a lot of like track athlete. Can you like introduce yourself a little bit? Like what kind of athlete you work with right now and like your background. Yeah.
Sure. Well, Eric, thanks for inviting me on. It's good to talk. I still do work with the likes of Dan and Stu and Kevin and Derek Heavey and those guys. So we're still connected. And my background is really started life in the military. They sent me through the university to get me qualified. And I worked in rehab there, particularly within the centers for the military guys getting affected by various wars and things. I got involved in Olympic sport and in sport really ever from day one, but Olympic sport in the middle 90s. And I've worked with all sorts of teams from um, winter sport to summer sport to Premier League soccer, as you would call it over there, rugby, and I still do to a lesser degree. Track athletes, so it's probably where I spent the last 10 or 12 years, bit longer working really. And I work with a number of athletes from around the world, but quite a few of our guys. I suppose I'm more of the sprint side of things. I spend more time in the sprint side than I do the endurance side, although I do see a couple of endurance athletes. And it's a very different mindset, as you know, from dealing with different types of athletes. I deal with some jumpers. Um, as well. So yeah, a fairly good mix. I quite like to have an eclectic group of athletes and not just the same thing. But if you think about it, pretty much most of them are still having to run somewhere to do something. Let's kick a ball, catch a ball, or whatever they might be doing. They're all basically running. So I suppose that's where I find myself. I'm not a coach. I don't consider myself an expert in anything at all. I've just been around a long time. I've been doing this for quite a while, and I've been fortunate enough to attend 8 Olympics with different teams, and including three with Canada. So it's been an interesting sporting life, and I've met some great people, and I've learned a lot from them. And I think that's the thing I enjoy most about working in sport, and is you increase your knowledge by working with lots of different people, from therapists to coaches to S&C coaches, and just people in general who just have a passion for what they do, and they've all got something to offer. So that's probably enough about me, I think. Hopefully, gives you a bit of an idea. Um, I'm a very pelvic oriented guy because it's central fulcrum, and if it doesn't want to play, then nothing else can play. So I do believe it's important to sort of try and get your head around that area. It's not straightforward. There's lots of different ideas. Um, but yeah, it's good to have ideas. It's good to have debates. It's good to have chats and discussions on them. And some answers are definitely wrong, but the vast majority of things we talk about, there's elements of right. And I don't think any one of us has got it completely right, because if we did, we'd probably be living the life of Riley now, and our feet up, flying in our private jet. And there's nowhere that's me. Okay, so hopefully that gives your listeners a bit of a background if they haven't heard me speak before.
Nice, nice. So, like I know you put up like education about like SI joint on the Altus education, which is like really awesome. I enjoyed it. So, but can you kind of explain like what like got you into like SI joint? Because like it's pretty complex, and like I work with physical therapists. I personally personally also help with athlete return to play, and SI joint is like like probably one of the most complex like joint or like part of the body. So what got you into like SI?
Well, it's a good question. And I think probably to start truthfully was failing to really get people back to where they thought they should be and I thought they should be. Also, the fact that nobody taught me in my basic training about the SIJ. We went from L5S1 to the hip, and we sort of missed out that big bony structure in the middle because back in the day, no one believed the SI joints moved. So because they didn't believe they moved, therefore no one bothered to do anything with them. And bearing in mind, I'm talking now, I trained back end of the very, very early 80s. And up until the middle, late 50s, we all knew the SIs moved. And then it was determined they didn't move. And it took quite a while, I think, really not until late 80s, early 90s did people start to talk about it again as if as a functioning structure that actually moved and did something. No one knows how much they move, that's for sure. And it's almost impossible to measure it in a living subject. So we know it's a few degrees, a few millimeters of translation, but each person's a bit different. So we really can't say. But logic dictates you wouldn't have a synovial joint that didn't move. No point having the synovium necessarily if there's nothing happening in there, you could argue. So yeah, it's a very that was it. And I was just thinking, well, this huge triangular bone at the base of the spine and these anomalies have got to do something. There must be something going on. So I started to research it. And I suppose it was then really then starting to read the work of Andre Vleeming et al. And the work of Diane Lee and others that I went, whoa, there's a lot more to this. So I sussed out the people. Another very interesting guy was Richard Don Tigney out in Le Havre in the States. He sadly passed now, but he did some great work on SIs and their function, both loaded and offloaded. So there's a lot of, and there's other people, I'm sure I've read lots of different people, but they're the people that spring to mind. I think they're the people that most people will, certainly with Vleeming et al., low back pain, the essential role of the pelvis, and the pelvic girdle stuff that's been put together by Diane Lee. So I think, and I think now everybody wouldn't even begin to think that they didn't move. I mean, it'd be like, really? But they didn't think they moved back and then. So for me, it was a start of a journey um, that has just become, well, I mean, without it now, I mean, I don't know what I'd be doing because it made sense to me the minute I began to understand them. I mean, oh my God, no wonder these things are real, they work. And of course, as we'll get into, if you can't load the SI, you can't move. It's real simple. It's that simple. Their job is to transfer effective load transfer, and if they don't and can't do it, you're going nowhere because we're designed to move. So then I realized how important they were. And so I started to get more and more into it, learn more, study more, take courses where I could, and started to put it together and started to think of it differently. And I suppose philosophically, the guy who then helped me to bring all this together in the 90s was Professor Yanda. And it was his work when I met him in London and then spent some time with him post that meeting that I began to think differently than the way I was trained to think, particularly with insidious onset problems. So it helped me to put together all of this stuff. And I'm still putting it together today. I mean, you never really ever get all the answers, but I'm beginning to put it together more effectively now and hopefully simplifying it, um, given that it is complex. But I think the best thing to do is to try and simplify it and to be able to do things with it so you can make a change because it's so easy for us to get lost in everything. So that's what I tried to do. I tried to keep everything very functional, and I tried to get away from pain. I'm really not interested in pain unless that pain is not a pain they should be experiencing. I respect they have the pain, but I don't chase pain. I basically chase the mechanism of the dysfunction. So why is this going wrong, basically? And if you need to understand why, and nothing avoids the sacroiliac joints. So gravity is coming down through to the ground and vertical ground reaction force is coming up. And so even every other force that's going on around the pelvis, all of these forces have to be transferred and pretty much the SIs are doing most of it. So to not work with them seems a bit pointless in my view. It's not the whole picture, but it's a big part of it, in my opinion.
Nice, nice. I like what you mentioned, like not you don't chase pain, you chase the mechanism, which is how I like help my athlete like return to play. So, and I know you kind of like uh talk a little bit about this, but like just for the sake of like helping like the audience like understand more, like what are some common like symptoms or like common like thing you see that's correlated with maybe SI joint like issues?
Um, okay, well, one thing I think we have to start with, we have to look at understanding what is an SI issue, which is a sacrum that is dysfunctioning on the ilia. And then we're looking at an iliosacral dysfunction, which is the ilium dysfunctioning on the sacrum. So, although it's the same joint, there are different types of issues that we need to think about. Um, and we need to also to understand that, we need to understand how the joints actually work. And they are diarthrodial joints. They are two very large, um, L-shaped or C-shaped joints, whatever you want to look at. They have um, they have different bevels inside the joint. The cartilage is smooth on one side and it is slightly fibrous on the other side. That's really important because the SIs transfer load via a change within the friction coefficient of the joint. Um, and and that is really important. And that is some of the work that came out of Leeming's group and on how we look at form and force closure or the self-braking mechanism. And that's all been put through. So if you understand that the makeup of the joint and the fact it's trying to transfer load, you can see whether it is or it isn't transferring. If you take pain out of the scenario, because there's all sorts of things that to differentiate the SI from the low back from the hip in pain is not straightforward. If you want to be a bit more specific, then you tend to find deep, dull aches within the gluteal region, you could argue could be considered SI, as in sacroiliac joint. So if we just say the sacroiliac joint, because we're not talking about the iliosacral or the sacroiliac dysfunctions at the moment, then you'll see that. But they're all interlinked. I mean, it's very difficult. If you've got an SI joint or an iliosacral dysfunction, you're likely to have a lower lumbar problem because the sacrum is attached to L5. So if I've got a sacrum that's not playing, then I'm going to have a change in my lumbar spine anyway. And if I've got an anomaly that's in the position of anterior rotation, for instance, or a pelvic tilt anterior or posteriorly, then I'm going to have a change at the hip as well. So you can't have one of these things usually without the others. So if we looked at the hip, SIJ, low back as a complex that all has to work together and in harmony, then it's a bit easier. Um, and so that is really what is happening. And, in that whole, then that's without looking at the whole pelvic girdle, which is a three-dimensional bony ring. And so if the symphysis at the front, which is an amphiarthrodal joint, if that's not playing, that affects everything else that's going on around it. So all of this stuff is interrelated. So it's never as simple as taking one thing, which is what makes it fascinating, but also makes it frustrating at times. Um, and then you've got all the muscles that attach around. They're all going to affect it from different angles of pull and different lines of pull and different force vectors. And so it's really very, very interesting. But it's got to be stable. So it has to be stable in order for it to take load. So you've got to have good stability. So in order to do that, you've got multiples of ligaments, massive ligamentous structures, particularly on the anterior surfaces, big ligaments posteriorly that help to control what's going on. You've got, like I said, around 35 muscles that will attach in and around the area, most of which are trying to stabilize it as opposed to move it. So I'm talking about it being the sacroiliac regions. So um, have I answered that question, or am I waffling a bit now?
No, you're good. You're good. That's
Um,
that's that's pretty good.
No, so if we take then the sacrum, if we move to the sacrum itself, so we'll look at a number of dysfunctions at the sacrum. Now, depending on who you read and who you listen to, there's lots of different thought processes. But if we keep it down to just a few axes, um, then we're looking at the sacrum it going into a nutation or a counter nutation. We're looking at it doing a side bend, and we're looking at torsions. If we just keep it at those level for now, then that makes it a bit easier. So we know there's not a lot of space in there. We know there's a lot that can go on, but it does actually move. Um, and a lot of those dysfunctions are down to probably in the main muscular fascial differentials that are changing the way that's functioning. But the first movement that has to occur if you want to get up onto your SI joints is you need to be able to give them is to make sure that the form closure, sorry, mechanism, which is an osteoligamentous stability, connects. In order for that to happen, the sacrum has to nutate. It has to move forward. If it doesn't, you can't increase the tension, therefore you can't take the load. So that's a structural start point. And the ligaments that are sort of playing a part in that control are the sacrotuberous ligament and the long dorsal sacroiliac ligaments. And there's others, but those two are the big boys at the back that are trying to stop it from going too far into nutation or too far into counter nutation. Counter nutation is required, but you don't want too much of that because it's not necessarily stable, um, as we just discussed there. So looking at those responses, you're going to get different types of torsional issues, and if you have a torsion, you're going to have a side bend. And if you think about Fryett, and a lot of people poo-poo Fryett, but he keeps it real simple, type 1, type 2, or neutral mechanics, whereas, within the spine particularly, whereas side bend and rotation occur to opposite directions. And in a flexed or extended position, they occur to the same side. Well, the sacrum follows the first set. It's side bend and rotation occur to opposites. So if you take that, that gives you an idea that if I've got a left-facing sacrum, I'm going to have a right unilateral flexion or extension, as we call it. We can't really get into all of that because it's really hard to explain, and you can't even learn it over a weekend easily. But there are things that are occurring within there. But the thing that is important about that is that the torsions will be affected by the ilia and by some muscles, particularly piriformis. Now, I'm not a fan of a piriformis syndrome. Piriformis is a muscle that has a role, but because of its attachment to the anterior surface of S234 and across to the greater trochanter, you could argue it acts like a prime mover of the sacrum. You could argue that fact. Because in order, when we're walking, once we bring the left leg forward and hit the ground with the left leg, the sacrum's going to rotate away and then towards, because it side bends as it rotates away. So that's going to be happening. And then as you swing the leg through, it's going to neutralize and then go in the opposite direction. So if it can't do that, you've got a problem. So if you had a problem with your piriformis, for instance, you're going to have a problem with your sacrum for some reason or other because it's not functioning properly. Who came first, chicken or egg? Did the sacrum go out and not work properly and the piriformis jumps in or whatever? But there's certainly things you have to be aware of and look at. And then you've got to look at ligamentous structures too that are around that area that will be affecting the function. If I've got a torsion at the sacrum, I'm going to have whichever way it's going, left or right, L5 will follow it because L5 is connected to the S1 of the sacrum. So if I've got a left-facing sacrum, I'm going to have a rotation same way in the L5. So we've got to look at that. And that will then affect the iliolumbar ligament, which will then change tension, which will also change what's going on. So the knock-on is right through the chain. It affects the muscular system because, we've got the long multifidus coming down through the sacrum and attaching into the pelvic girdle. It attaches onto a lot of different structures, but one of the things it will hook onto is the sacrotuberous ligament. And it doesn't do that by accident because it's going to pull on that, which changes again the tension within that ligament, which would change what's happening at the sacrum. So I think it's not for this podcast to get involved in sacral mechanics because I think that is too much. But just to give you a little bit of an idea of the complexities of things that are occurring which is why it's not as simple as let's just stretch that muscle. When I'm teaching to people, I always say, if you don't know why something's tight and stiff, don't touch it until you do, because you need to understand why the body's reacted the way it's reacted before you start to change it. If you go in and change it without knowing, you have no idea what the body's going to do next. And once you set it off on a journey that's not the right direction, in an athlete particularly, it will rapidly go the wrong direction. So you need to try to understand the direction of travel that the body's trying to take itself in and get behind it and follow it rather than thinking we know better than the body in front of us and go in the wrong direction. We as therapists have a bad habit sometimes of getting in the way. We don't intend to, but we often do. So Mel Siff puts it really well. He says, the body's an amazing organism. It understands its timings, its mechanisms. It understands what to do. But every now and again, there are blocks to progress. Our job is to find the block, remove it, and then get out the way and let the body move forward. Um, so I'm a big fan of that. I'm a big fan of listening to the system, understanding where it wants to go, and supporting the system in the direction of travel it wants to play. And yes, I've got to remove those blocks, and those blocks may require me to manipulate, mobilize, stimulate, stretch occasionally, release. There'll be a number of ways in which we can remove the blocks, but first of all, understand where they are and why they're there, and then you can move forward. So, yeah. I don't know whether I'm still answering the same question. I'm just rambling, but
No, 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 no. That's awesome. That's like really awesome because like the way you kind of explain how it moved how the sacrum and the iliac and how the hip moved like during walking, it kind of like remind me like a conversation I had with Dan, and Dan Paff was like, we were talking about like 60-meter sprint and he's watching the video on rear view of how they experience it. This athlete has sacrum issue. I'm like, what? I'm like, what? How the, how the hell did you know that? I'm like, oh shit, I need to
yeah, no,
learn more about that.
Dan Path is a unique, extraordinary individual, and there's probably only Dan Path that could probably see that. But you can see if you understand how it works, you will notice that there's a problem. So, for instance, if I cannot get the sacrum when I put my left foot down to the ground to rotate to the right slightly and side bend in, then you will see an aberrant pattern. And you may not know it's directly the SIJ, but if everything else looks like it's moving okay, if the knee drive looks okay and the contact looks okay and recovery pattern doesn't, but you probably find that it's in the knee drive you'll see it not working because if the SI doesn't want to load, then you won't be able to get that knee drive through and get onto the ground the way you're meant to in order for the SI to take the load. So you will see that. And it's only a trained eye like his over the years that will negate quite quickly the other potential factors that may be involved. I think the key thing is to accept that it's central to all of these things and to look at something that's not moving well and not look at that proximal end first and have a look and see what is that sacrum SIJ doing, the hip doing, and then travel down to the foot. Now, it might be being generated at the foot, but it's important to know that that's sitting first, in my view. Um, um, and I think because of that, because it's um, so integral to the way the load's being transferred, it's hard. You've got to, you've got to get that central proximal end sorted to allow you to look further down the loop. But like I say, it's quite possible it's all being generated by the foot. But yeah, it's an interesting way to it's interesting to look and see. And I would always suspect if there's a problem with the way they're moving and getting onto the shortening the step on one side rather than the other, you'd have to ask yourself, why is that? And there's probably about 15 different reasons. And if your name's Dan Pap, you can probably end up with two or three pretty quickly, very closely on the money. Um, Sadly, I'm not a Dan Pap, so I can't, I wouldn't profess to do that, but I would know to look at it, that's for sure.
Nice, nice. Cause that was like I don't know. I remember that was like really cool that just how see how they spring and he kind of mentioned like what you said, the knee drive is a little bit different, like from right to left, and the stride length is a little bit different from right to left, and how the hip rot like how the iliac rotate is kind of different from right to left.
Correct.
It's like what you just mentioned. It's pretty
Yeah.
awesome.
Well, if you think about this, right, there's the bicep femoris of the hamstring, particularly, but the hamstrings are secondary stabilizers of the sacroiliac joint. So if my sacroiliac joint isn't stabilizing, then when I drive through that on that, say on that left side, then that if that hamstring's already not happy because it's trying to prepare itself to stabilize my contact, I'm already in trouble. It's already trying to stop my shank from going too far and trying to bring my foot to the ground. You with me? It's already doing a lot of that. But if the SI joint is asking it to also help stabilize it just as it's going to hit the deck, it's going to have to shorten. Things are going to have to change. So, the hamstring may be very tight, but part of the reason it's tight is it might be because of the SI and other things as well. Like I say, if it was really that simple, we'd all be fixing it tomorrow, every day. But it isn't that simple.
Nice, nice, nice. So we kind of already talked about like how can we like without like doing assessment, table assessment or like standing movement assessment to figure out if they have like a side joint issue. And I know you already did like the education with autists about like talk about like, how you assess like SI, but can you like kind of like go through like your assessment process for SI joint? I know this is like really difficult.
Yeah, sure. No, I'll do my best. So what I think you've got is, what am I doing? So simple things to look for. Because we know the SIs have to stabilize. One of the ways you can get an idea if they're not working very well is if people find it difficult to go from sitting to standing, because that is going from sitting to standing. They have to load the SI. So can they do that? When they stand there, have a look at the width of their legs in the normal relaxed stance for them. And if they're standing outside their shoulder girdle width, then the chances are they're attempting to put forces in through the hip, which are no longer coming up through, but coming at a slightly different angle to give more forces into the SI area itself, around about S3. And then if they're standing with their weight towards their heels, then they're probably trying to also increase the posterior chain tension, also to try and increase standing stabilization at the SI. So they're things you can look at and go, okay, why are they doing that? And that's probably because they're attempting in stance to try and stabilize a bit better. And then when you look at the moving, then you want to look at if they're flexing forwards. If you get under the standing flexion tests often get poo-pooed as being irrelevant. There's no specific test really outside of pain provocation for the SIs. It's a combination of a number of different factors that you bring together, and then on balance, you go in balance. I think it's this or this going on. So a standing flexion test, as you come under the PSIs and they flex, you're looking at whether or not there is a relative counter nutation of the sacrum, and you might see that left isn't and the right is. That's just a test. It doesn't tell you any more than that. It's not a determining test. You can then look at the way they flex and extend at the spine. How does that look? Is that smooth? Is it controlled? And if it's controlled, you'll see that the spine moves smoothly down into flexion and comes back into neutral and into extension, which is you could argue is hyperextension really because they've already come back from flexion. And the way that they move down is important because if it's a smooth, well-controlled movement, then you'll see that. And that's really because the acceleration, deceleration around the joint is what allows it to be smooth. So that will give you an idea again whether that's coming out of there. Then I'll look at, I've done a little test myself where I get on the greater decanters and I go to sort of where I believe the posterior hip is on both sides and get to flex again and see whether or not there's a movement in that area. Then I will look at the Gillet test or a stalk test. Again, people knock that test. Well, it's a decent test. It looks to see where you are engaging your hip with the pelvis. And again, you can look and see whether the sacrum, how the ilium is moving on the sacrum. Um, and then that's just in standing. And all of those things in standing are really important because they're all loaded. So when you take them offload onto the bed, then you've got to look at it slightly differently. So you're looking at the position of the sacrum, which you can do by getting to the sulci and seeing whether the sulci is where it's at. Get on the inferior aspect of the inferior lateral angles of the sacrum, and that will give you an idea of potential side bend. Get up onto their elbows to see if there's any rotation going through the low back into S1. And sit them flexed on the bed, which will give you an idea of whether again there's dysfunction, but also if you suspect a side bend, you don't know which side it is. So by doing a seat deflection test under the PSIS again, whichever side is going up, um, and whichever side you feel is off, it will give you an idea whether you're treating left or right side, and whether it's, again, without getting complex, whether it's a flexed or extended problem. These are, I'm throwing bits out there, but it's too complex to go. I mention it just to mention it, but people can look it up and they can get into it and read and attend courses for it. But it's a couple of days of study on a course to get sacral mechanics. It's not a walk in the park. So that's what I'm going to do. Then I'm going to look at the muscles. Okay, so are the anterior and posterior chains doing? Are they tight? Are they firing as they should? Is how are they going to extension? How are the hip into flexion? Remember the hip extension being the most important movement, coupled with that with internal rotation, which we need to be able to move. So again, how is that going? Is that timing right through the spine, through the pelvis? Um, um, is it compressed? Is it rotated and stuck? Because anterior iliac rotation is a physiological movement. It's designed to happen, but sometimes it sticks and sometimes needs to come back. The L5S1 can be compressed. The hip can be compressed. So there's all of these things you're looking for because they will be either a direct effect or an indirect effect from the SI. So these are all the things I'm looking at. And then when they're moving, if you know how they're looking, you'll see that it's just not right. But like I said, it's a complex of hip, SI, spine. It's not, oh, that's the SIJ, because it won't be in isolation. Remember, nothing in the body works in isolation. Everything works together as a team, or not, as the case may be. And as I say to my people, who isn't playing nicely with others? Who's not talking to the rest of the team? And then the job is then to get them talking.
Nice, nice. I remember uh, so I kind of did this I think it's called kinetic control.
Yeah, kinetic control. Yeah, Mark Comerford and people.
Yeah.
They're
So
very
I
good.
I did this kinetic control course in Taiwan, and they talk about SI joint for like 4 days.
Yeah,
Yeah, I think 4 days if I remember it correct. And so I before I did that, I already did like SFMA and like NKT, all those like physical therapists, the courses they did. It was like fascinating, but sometimes they're just I sometimes they're just like pain, like you mentioned. Maybe it's pain or like something in the hip or at the low back. The athlete like don't know or like don't know how to tell, just feel like something weird. So that got me into like this SI gym. So I did this like kinetic control course, and uh I know I'm like it's not 100% the same, but it's about it's about the same. And one thing I do notice is I don't know why after I like learn like the kinetic control about like SI joint, feel like it's like you mentioned, it's not a lot of times you'll think it's SI, but maybe it's stuck at iliac, or maybe it's the pelvis, or maybe it's like the shit, forgot ischium, maybe it's the
yeah.
ischium that affect the SI. It's like you mentioned, it's never the isolation of the S like sacral joint.
No. But kinetic control is very interesting. It is quite their stuff can be quite complicated, but it's very good. And again, it will help you to understand how things are connected and how they work together and how sometimes they don't work together. And yeah, absolutely. So I mean, that's hardcore training, I would say. Because that's the vibe. I have attended in the early days when Mark Comerford first came across the UK. from Australia, I did a lot. I did all of his courses.
Oh, really?
Uh, yeah, and I found them really, really useful, but quite theoretical. Very,
Yeah.
it's much more practical now as well, but it was very theoretical then, and it was like, whoa, but really good stuff. I mean, and these people, people have done a lot of work. There's been a lot of research those guys have done. It is a really good course to do. And they go through the whole system. They go through everything.
Yeah.
But again, each person's got to find their own way. So you've got to find what works for you, and not everything that I say works for everybody. Not everything they say works for everybody. You've got to try and find what works for you. Take the things that you feel work for you and keep them, and dump the rest. Because you don't want to try and be somebody else. You have to be you. So as you inform yourself and as you educate yourself and as you learn things, you've got to determine, as I say, what really does work for you. What can you then apply, and how much do you understand? And we don't all have to be experts. Remember, experts are an X is a has been, and experts are drip under pressure. So we don't want to be we don't want to be experts.
Nice, nice. So, uh, we talk a lot about SI, how to assess SI, and we talk about like kinetic control, all those stuff. So here's the thing, like I don't know, maybe it's my population or like the athlete I treat. I I don't know, is after I learn like the like deeper dive into the kinetic control, how to assess I figured out that there's not a lot of like athlete have SI joint issue. Maybe it's my population. So my question to you is like, is there like from day to day like patients or like athletes, is there a lot of like patient athlete that they really have like issue at their SI iliac or like ischium at that area?
Well, it depends what you mean by that. If you're saying, do they have painful SIJs or SIJ type symptoms? I mean, there's lots of different symptoms that will be related. Don't forget, athletes are putting a lot of load through the body, so the chances of them having some dysfunction within the iliosacral, sacroiliac, hip, lumbar spine region are fairly high. Whether it's the SIJ is just a small part of that, the sacroiliac joint, but it's got to load, so it doesn't matter if it's depends how you determine it. If you're talking about pain from the SI, probably not a lot of, there's probably not that many that have physical pain from the SI unless they have a inflammatory process within the sacroiliac joint itself. It would be because of that they've got pain. Most of the time there's an ache and other things are under pressure. So yeah, I mean, I think it's hard to determine um, it depends how you're seeing the SI. Like I say, if you're looking at it from a pain perspective, you might not see too many with painful SIJs unless they've really have got a local inflammation within the joint. Um, but you will have this nagging sort of dull, deep ache, or you'll have other things that are not functioning, and whether they came first or last, who knows what came first. But you can't have issues of loading at the hip and not have issues of loading the SIJ, and vice versa. You're not likely to have a loading issue at the SIJ without something at the hip and low back contributing somewhere. Um, and often as well, don't forget that's if you're looking at form closure, just normal ambulant gait. When they're running, then you need to have shoulder girdles that function well, because if the shoulder girdles don't function well, then the posterior and anterior oblique slings, particularly the posterior oblique slings, that are really important for increasing force closure around the pelvis to increase that friction coefficient, then you're going to have a big issue there too. And again, the long two joint muscles. Remember, the SI joints have to be able to take load for you to move. So they will pull from any fascial muscle connection they can for them to stabilize. And that's often when people stand and they're all crooked. Yes, they may have a disc issue, but it might be second to the fact the SI can't load. So it will pull and tighten up anything to help it to stabilize because you're asking it to move and to work. So I think it's very difficult to say, oh, that's definitely just the SI, because I don't think that I see just the SI. I think if they're in balance, if they're stabilizing well proximally, if they're appropriately strong through the key areas, and they're technically running well, then yeah, they you will see most of the time they can cope. They're going to get compressed. It's normal. The L5S1 or the LSs are going to be compressed things because that's what they're doing. But if it's bilateral and their systems are in good working order, then yeah, you won't necessarily lots of big time dysfunction, just small little tweaks here and there. People who are don't run and train all the time and go out running at weekends, they're probably going to see more dysfunction because they're not conditioned appropriately to take the load. So they're probably going to see much more obvious problems.
Yeah, that's probably why like one of the physical therapists I like went to course with, he said like he see more like SI joint issue in like just non-athlete population.
Yeah, because they're not, they won't be as in the main as well conditioned. They won't be taking as much load unless they're weekend warriors or trying to run around the back garden with their kids, and they don't do it all the time, and they're not you can't ask the body to do nothing for ages and then suddenly do it and expect it to do it, because funny old thing, it will try, but it has to make a few changes to you to allow you to do it. And then after you stop, it goes, whoa, it didn't like that very much. So, you're forcing the body to adapt and to change. Don't forget, it'll do as you tell it to. If you tell it to go run and jump, it'll do it. If it can't do it the way it wants to, it'll find a way to do it. It'll make a change here and there to do it. And then you've got to deal with that change afterwards. And your body might say, I didn't like that very much. So people will live a linear life in the main, and then they want to go and do a rotatory type job. Like I went out and played five-a-side soccer for the first time in 10 years, and they can't understand why their body's in bits. Well, you haven't made it do that forever. So it's not, it'll do it, but you're gonna pay for it.
Nice. And I'm glad that you brought up rotation because this is actually the reason why I wanted to invite you on talk about SI is because like uh 2028 Olympic is at LA and I think they included I forgot it's field hockey or lacrosse as a sport to like LA Olympic and like what they found out is like a lot of the field hockey or lacrosse player, they have like low back pain. And they, according to what they say, it's a side joint issue. I don't know because I don't deal with lacrosse or field hockey. My main population is basketball and sprinters. So I don't know enough about like probably rotational sport. So uh can we like dive a little bit deeper into like oh this is also why at the first place I send you questions about like scoliosis because I know like if the spine rotates this way I don't know like which one is the cause if the spine rotates this way and the side probably will rotate other way it depends on the ridge like where the spine rotates of course but like can you kind of explain a little bit like your thoughts on like the rotational and how that affects like hip, iliac, and the sacrum. I'm sorry, I'm like talking a lot.
No, no, it's okay. You carry on. Well, the spine has to rotate because if you follow the work of Grakovetsky, which is basically the spinal engine, who believes that the spine drives gait and the legs merely amplify gait, then if you look at the shape of the spine and you look at side bending, for instance, that will cause rotation. Um, and that all of these things sort of fit together with Freihert's rules about side bend rotation going opposite directions. So that sort of thing. So yes, if I'm in a flexed or extended position and trying to rotate and drive off and move in different directions, I've got to be able to control that. So it's quite possible that if my rotation of my spine, which will cause the sacrum to move, so if I've got L5 on S1 and L5 is being pushed into a position, then S1 will try to follow. If I've then got a leg doing something else in a different direction, which is asking it to come in a different direction, then I will potentially rotate through my innominate and get stuck. So my innominate sticks and it holds my sacrum in position. Now my low back can't get out of the position it's in. So I'll start to adapt through and get a bit stiff. And once I stop, and stiffen up, then things will start to ache and hurt. So there's a lot of multiple and multi-directional vectors going on around the low back, hip, pelvis, all at the same time. Now, most of the time, depending on how we do it, our body will deal with that. There's enough tolerance potentially if we're well trained to deal with it. But there are times when that won't be the case. And is it SIJ? You could argue any aberrant loading is SIJ, but it's being driven by lots of other things. And I think we've got to be very careful with this saying it's SIJ because the SIs, if they're being properly stabilized, then they should cope pretty well. But the innominants are going to rotate. It's a physiological movement. They're meant to do this. The muscle to length tensions will change, and depending on how much stress we're putting through at any one time, it's like a conductor in an orchestra. There's so many moving parts. You can't just say, oh, well, it's down to that. Ultimately, if the SI eventually dysfunctions because of these moving parts, then the whole system will start dysfunctioning, will stop functioning normally. And the SIs can be blamed ultimately because they are the ultimate arbiter. If they stop loading, you're not moving. So, is it their fault? Possibly not. There's lots of other things going on, particularly in sports like hockey and field hockey, when you're in a flex position, running a lot, bent over. I mean, being bent over is not an issue, but when you bend over and then combine movements of flexion, potentially flexion, rotation, side bend all at the same time at speed, and then you've got other things happening, then yes, it's a recipe for things to not necessarily work properly. But if you're well trained at that, then it's used to it. And don't forget, being flexed over fascially, the lumbar fascia, sacral fascia is bloody strong. So it's going to hold on to you quite happily. It all depends on position. Like I say, none of these things are straightforward. But I think if you have a number of things, a number of characters involved, then depending on the movement, depending on the fatigue factors and everything else you've got to do, then some are involved greater than others. But ultimately, all roads will eventually end up leading back to the sacroiliac joint being able to work. It doesn't mean it's his fault. It just might be that it can't function in the environment that you're putting it into. So that's why we train these things to get them more effective. You don't have to be super efficient to be effective, but it's good if you can be. Um,
Nice.
you know, so it's things like that we're working through, and therefore, if you work logically through the movements that occurred in the sport you're looking at the type of movement, you know what to look for when you look at the body and say, okay, well, how capable is it of doing this particular movement? And if I combine these movements together, what is the outcome? And each person will handle it in a different way because they're different heights. So you might find you've got shorter people and taller people playing the same sport, and they'll have a different set of issues. Some taller people might have some scoliosis. Well, that's okay. If it's an adaptive, it depends whether it's an idiopathic scoliosis and you're born with it or through growth, or whether it is an adaptive process because you've done something to yourself. Fractured your femur at some point or your tibia at some point, and you've now got a shorter leg. So it depends on where it's at. And, these adaptive processes, even in growth, can be fine. It's then looking at that's all of these things are coming into the pot. But that's just another thing, a factor you have to build into your assessment and your management. And just because you have that doesn't mean you can't do it. I mean, none of us are symmetrical and none of us are perfect. And even if you took the most amazing sporting people in the world, they're not perfect.
Yeah.
If you were to look at, say, I mean, yeah, it doesn't matter. If you look at some of the greatest athletes around, I'm pretty sure that everything isn't super symmetrical. And, you know, just because of the way it is. And, you know, as we load things more and more, is loading always in parallel? Is everything always loading the same amount each side? No, it's not. So again, there's these imbalances. So you've got to balance them up again. Again, you go into the kinetic control stuff there. But but understanding how it's supposed to work, understanding the types of pressures and stresses it's under allows you to adapt the training of process and adapt what you're doing to improve your ability to take that amount of stress. So yeah, again, I don't mean to be nebulous and not, but I just don't think you can make a statement like, "Oh, the SIs are the main issue." They're certainly going to be the main issue when you start function very well, but they may not have started the problem. They may be at the end of the road.
Yeah, yeah, I like it. I like it.
Yeah. So who knows? Who knows? What do I see? Yeah. Do I see it involved? Yeah. If they're not moving very well, I'm always going to find something within the SI that doesn't play nicely. But I don't know whether that was, whether that's the first thing I found or that come at the very end,
Yeah. Yeah,
you know?
exactly. Exactly. So, last question before I let you go, and this probably also gonna be a big one. So there's like motion capture right now, like 3D motion capture. Like every company want to be the best. And like I mentioned, like 2028 LA Olympic, they're gonna spend a lot of money like doing tracking like the stick, tracking how the body move. So if we're gonna focus on like or help understand or dive a little bit deeper, help them dive a little bit deeper into like the whole lumbo-pelvic SI joint issue, like where are the areas you think we should track?
Oh, blimey.
I'm sorry
That's
to put you into
actually
the position to answer
That's
that.
a that's I mean, to be fair, I mean that question's not so much in my purview. I mean, that's the biomechanists, and that's really their expertise to look at, because that's a huge question. That's a huge field. And yeah, it's not an area that, I would necessarily think about particularly. If I looked at them track when they're doing their base, if I look at when I work alongside biomex and we look at running and the way the body's dealing with all these different forces, then yes, I can correlate that and work that through with what I'm finding and seeing practically, clinically, or out on when they're running. But that's their thing. That's not my bag. That's their thing. And I'm pretty sure that getting a good biomechanist on, we answer that type of question for you because that's what they do. I would utilize the information based upon my finding. And if someone asked me with a Pacific athlete, we're noticing this and I've noticed that, I might say it would be really good if you could track, maybe look at how we track this and can we track this? But that's their expertise, sadly, not mine. So I would be scrambling a little bit to try and answer that question. But it's look, data collection is always useful. It is only what it is. It's data collection. At the end of the day, you as a coach, me as a therapist, we have to work with what we have in front of us and what we're seeing and what we're trying to achieve with it. And as to help us, the data collection, whether that be through capture on a treadmill, capture through an up jump, capture on force decks, capture on some of the other systems that are out there now that are attaching to people and giving info. They just give us information. And that's their role, to give us information. It's not to make decisions for us. You as a coach, me as a therapist, utilize the information to try and make better decisions. But we still have to make the decision. We still have to get the information and utilize it. And that's what I do with the coach. I don't tell the coach what to do. I'm merely an advisor. I give the coach the information that I've gathered on their athlete, and that's what I do. I give them the information. So that's what the biomech would do about what they've tracked and how they see it. The coach then makes a decision on what they want to do with the information. Now, if the coach was to say to me, "What would you do?" I would give them my thoughts, but I wouldn't offer my thoughts firsthand because that's not my role. My role is not to make decisions, it's to provide advice. So I would provide advice to the coach on what I'm seeing, what I'm thinking, and leave it to the coach to make a call. And the coach might say, "Yeah, but I'm not sure what to do with this." I say, "Well, maybe look at this and this." But bear in mind, I'm not a coach, although we're all sort of coaches in some way, shape, or form. But I'm not a specific track coach or a specific jumps coach or a hockey coach, or, well, I am actually in hockey, but basketball or whatever sport it might be, soccer. Um, so, yeah, but the interaction with coach and therapists is a really important one. And then with biomechanics, it's important. With all the various people out there that are trying to help a coach to get a better athlete, all of that information is useful, provided it's joined up and we can understand it. And you know as a coach, sometimes you may say to me, is there something going on in that hip or SI or that foot and ankle or whatever? Because it doesn't look right to me. I think this is happening. And it might be that I don't see anything, but so well, let's have a look what it loads in. Well, let's put it under load and see what it does. So maybe the vortex help us. Or maybe we put them through an optogen and go, oh my God, look at that contact time. It's terrible. Um, and so then we can work, we've got something else. You've seen something not right. We may have looked at it and gone, well, that feels that's too stiff, or that's not stiff enough there, or that, blimey, that longitudinal arch is not recoiling, not responding when the foot's off the ground very well. So we can change those things and see what that does to the rest of the system. Um, and if you're still not getting there, then this data collection could be very, very helpful. Um, but I worry sometimes that we're going to go data mad and we're not going to necessarily we're going to stop thinking for ourselves. But yeah, I think the best people out there, it's how they use the information they're given. And I think from a coach's perspective, the best coaches probably use the information really well and know how to translate it. And yeah, I would say that's probably what happens. Um, but yeah, from a point of view of what we should mark and what we should track and what we should look at, no, I'd leave that. I'll leave that to the biomechanists. That's their realm. They're the people who will know when you set out the parameters. But you have to set out the parameters first of all, um, and it's hard to do. I mean, it's really hard to do. I mean, there's little things now that sit on the back on the sacrum, and they can look at various bits of information. But how valid is it? What do I need to do with it? What is it really telling me? How does that affect the performance of the athlete? And there's lots of it coming out with lots of different bits of kit out there, but you've got to know what it's actually saying and what it and how helpful is it? And is it what you're looking for? Um, so yeah, it's a minefield, that is. But it's going to get greater. And of course, what's going to happen is you're going to start to get AI doing its thing. So it's a changing world, and lots of things are changing, and change is often good. And I'm at a stage in my career where I'm towards the back end of it now, so I don't have to worry myself in getting myself up to speed with every little thing that's changing in that sense. Um, but the youngsters, yeah, it's the way they're going to come through, and who knows? It may answer a lot more questions, but it may ask a lot more than it answers. Who knows? But everything's changing, and change is inevitable, and you've got to run with it.
Nice, nice, nice. I love it. I love it. And man, I love every part of this because I enjoy like I think the first day when Altus like launched like the course, I was like I enjoyed that. And like I mentioned, I did the KC kinetic control. And so today, like the stuff you mentioned, it's kind of amazing that I kind of understand most of it. It's pretty
Oh,
cool. So
that's pretty cool. Yeah, well done.
yeah, and the way you explain it, it's like you're not just a physical therapist. You understand like how human body move, how they sprint, how they change direction, how they walk. That's awesome.
Well, if I tell you that, I have to thank Professor Yander for that. Because when Professor Yander and I met, he said to me, if you don't know how the body works, then you don't know when it's not working. If you all you then do is follow symptoms, and if you follow symptoms in most insidious onset problems, you'll fail every time. So learn how the body works so that you know when it's not working. And by knowing what's not working to get it working, then you're likely to solve the issue. So that's the most important thing. If you follow symptoms with insidious onset problems, i.e., problems that have come out of the blue, you'll fail every single time. And that I always remember they said that to me. Um, and I've also, my own little gem in there is that I look at treatment as merely a physical question, not an answer. The treatment is merely a question that I want the body to answer. And if the body says, yes, please, I like this, then it changes. And if it doesn't like it, it doesn't change, not for the better anyway. So think of it all the time of trying to understand where the body wants to go, but you need to know how it works. And leave you one last thing with that. What he meant by that was when the foot strikes the ground, what happens? Meaning, what muscles contract, what joints stiffen, when do they stiffen in the process, and how do they transfer the load? Not we go into a single leg stance phase. So that's what he was talking about. And then what preemptively happens on just before you strike the ground? What is happening through the chain? And if you understand that and what is meant to happen, for instance, as an example, then you can look for things that aren't working. But if you don't know it, you don't know if they're not working, which means you'll just go to symptoms. And without his input, without him beating me on this for years, well, not enough years, thanks, because I met him in the back end of the 90s, 96. He died in '02, which was a real shame. Um, but I owe a lot to him for basically giving me a hard time on this to make me think differently. Because we're not generally as therapists trained to deal with insidious onset. We're very well trained in dealing with cause and effect, disease, post-operative care, all that stuff. But when it comes to the insidious onset world, we're not specifically trained for it. Well, I certainly wasn't. I can't speak for future generations, but I certainly wasn't. And so he was a revelation, it's an epiphany for me. It's like a big beacon went off in my head. And I knew that was what I was missing. And I'm still working on it today. And so that's, from 1996 onwards. So it's a big area, but that's something people need to think about. Um, and so anyway, so hopefully that's been helpful.
It is. It is. It is. It's awesome. It's awesome, man. I
Cool.
appreciate you.
Not at all. Well, thanks for inviting me on, and I hope it comes out okay.